All right, for this explainer, we're going to put on our detective hats. We're stepping into the world of radiology, but we're not just looking at medical images. We're treating X-rays like a crime scene, a place filled with these subtle, hidden clues that tell the whole story of what's really going on inside a bone.
So, picture this. You're looking at an X-ray, and there it is, a spot, a shadow on a bone that just shouldn't be there. And right away, you're at the heart of the mystery. Is this some old, harmless thing, or is it a sign of something aggressive, something really dangerous? The stakes? Incredibly high.
So, how does our lead detective, the radiologist, even begin to crack this case? Well, according to our source material, the entire investigation hinges on one single critical question. Is this lesion aggressive? That one answer guides every single thing that comes next. So let's open up the case file and see how they figure it out.
Our very first piece of evidence is found at the perimeter of that shadow. We're talking about the border, or what radiologists call the zone of transition. This is the line in the sand where the lesion meets normal, healthy bone.
You might be thinking, how can a simple line tell you all that? Well, it's pretty incredible. But the character of this border can tell you almost everything you need to know about the lesion's personality. It all boils down to speed. How fast is this thing growing, and how is the bone reacting to it?
And this slide just illustrates it perfectly. On the left, we've got a benign lesion. See that sharp, clear border? That tells you the bone has had plenty of time to say, whoa, hold on, and build a protective wall around it. But then look at the right. The edge is blurry, it's fuzzy, it's indistinct. That's a wide zone of transition. And that, my friends, is a huge red flag. It's screaming that the lesion is growing so fast the bone just can't keep up.
You know, the source material for this has a brilliant, super simple way to think about this. Just ask yourself one question. Could I trace the edge of this thing with a pencil? If the answer is yes, if you can draw a nice clean line around it, you're probably looking at something slow-growing and benign. But if the edges just kind of fade and blur into the bone around it, you're dealing with something way more aggressive.
Okay, so we've checked out the border, but the detective work doesn't stop there, not by a long shot. Now we have to look inside the lesion to find our next clue, the pattern of destruction. See, it's not just that the bone is being destroyed, it's how it's being destroyed that really gives the game away.
Basically, our detective is on the lookout for one of three signature attack patterns. You've got geographic, moth-eaten, and permeative, and each one tells a very different story about how aggressive our culprit is.
First up is the geographic pattern. Think of this as one big, well-defined hole in the bone. Because it's a single contained area of damage, it usually means we're dealing with a slower, less aggressive process. The culprit is taking its time. Then things get a bit more concerning with the moth-eaten pattern, and it looks exactly like it sounds, like a moth has chewed a bunch of small holes in the bone. The source compares it to a spray of buckshot. This pattern is way more suspicious and suggests a tumor that's growing and spreading fast. And then you have the most aggressive pattern of them all, permeative. These are tiny, ill-defined, almost streak-like holes that make the bone itself look porous. This isn't just a hole in the bone. This is a sign that the tumor is weaving itself through the very fabric of the bone's structure. This is classic for really aggressive cancers, like Ewing's sarcoma or myeloma.
All right, so we've got our key clues, the border and the pattern of destruction. Let's use them to build a profile of one of the most notorious bad guys in this world, osteosarcoma. And if you look at the numbers, you'll see why it's such a prime suspect. Yeah, myeloma is #1 overall, but osteosarcoma is right up there, tied with chondrosarcoma. It's common and it's aggressive, which means it's always high on the list, especially when the patient is young.
So who is this prime suspect? Osteosarcoma is a nasty type of cancer where the malignant cells themselves start producing their own shoddy version of bone, or what's called osteoid. The classic patient profile is a teenager or a young adult, and the most common crime scene, by far, is right around the knee.
And like any good movie villain, osteosarcoma has its calling cards. These are telltale reactions from the periosteum, that's the outer layer of the bone. You might see a sunburst reaction which looks like spikes of new bone shooting outwards, or a lamellated reaction which has this onion skin look, or maybe the most famous of all, the Codman triangle, which is this little triangle of bone that gets lifted up as the tumor busts through the cortex.
But hey, a good detective knows it's never just about the prime suspect, right? You gotta check out the whole lineup. So let's quickly run through a few of the other usual suspects.
Remember that really aggressive permeative pattern we talked about? Well, if you see that pattern, specifically in the diaphysis, the long shaft of a bone, and it's in a child, your alarm bells should be screaming Ewing sarcoma. It's what's known as a small, round, blue cell tumor, and its appearance and its location are just classic.
Now, this next one, this is a tough case. It's where the detective work gets really subtle. You're trying to tell a benign cartilage tumor, an enchondroma, from its evil twin, chondrosarcoma. The source gives us some handy clues. The malignant one tends to be bigger, over 5 centimeters. It causes pain, and it starts doing more aggressive stuff, like actually destroying the cortex.
Okay, for our next suspect, I've got a fantastic little memory trick for you, straight from the source material. It's like a call and response. Ready? I say chordoma, you say midline.
And there's a really cool reason why that little trick works every single time. Chordomas, they actually grow from leftover cells from the notochord, which is this structure from when we were just embryos that helps form our spine. Because of this unique origin story, chordomas are only found right along the central axis of the body, the spine, the sacrum, the base of the skull. You will never ever find one in an arm or a leg. It's a hard and fast rule.
All right, the clues have been gathered, the evidence is weighed, the prime suspect is identified. The case is cracked, but the real work is actually just getting started. Let's close out our case file by looking at what happens next.
So if the verdict is osteosarcoma, what's the plan? Well, it's a whole pathway. After the initial X-ray, you get an MRI to map everything out and plan a biopsy. The biopsy gives you that 100% confirmation. Then, usually, the patient gets chemo before surgery to shrink the tumor down. Then comes the surgery to cut it out, followed by more chemo to clean up any stray cells. And after all that, years of careful follow-up.
And you might wonder, why is that follow-up so intense? It all comes down to this one staggering number, 80%. That's the percentage of the time that if osteosarcoma comes back, it comes back in the lungs. And that's exactly why a chest CT is an absolutely critical part of the initial investigation. A good detective can't just focus on the primary crime scene. They have to check for accomplices hiding out somewhere else.
So, there you have it. From a simple blurry edge on an X-ray to a pattern of destruction inside the bone, we've seen how radiologists are basically detectives, piecing together visual clues to solve a life or death mystery. It's a powerful reminder that every single medical image tells a story, and it really leaves you wondering, what other hidden clues are out there waiting in plain sight, just ready to be found by the right detective?